cloud. Perfect. Okay, so we're recording. So this session will be posted as well on Osler as soon as possible. Hopefully, some point tomorrow I could see being possible. Anyways, you guys have a test coming up Wednesday too. So kind of in the question and answer period, we kind of open things up a little bit, even if it's just something we peripherally touched on, and we can try and answer your questions as best we can. So lastly, let me just try to get the chat up here. And we can see if we can avoid some of my technical deficiencies. Okay, great. All right, so we'll get started. So this is diabetes lecture, and really, especially myself as a generalist, as mostly working in the community, you see type 2 diabetes a lot. So a lot of this can be framed towards type 2 diabetes, but essentially type 1 diabetes, its differences will be highlighted along the way. But definitely if you're confused about my slides in terms of like, does this apply to both? Does it apply to type 2 or type 1, etc.? We'll kind of get into that, and it should be labeled. But if you have any confusions, I really want to keep this thing clear and give you guys like a good, solid, strong framework that doesn't get confusing. Okay, so without further ado, we'll just jump right into the first slide here. So essentially, what diabetes is an issue with this pathway. So this is a very simple pathway. And essentially what you have to think of sugar as is like this really valuable golden vital molecule that is something that humans seek out and they crave and they try to get as much as they can of. And so there's these really complex interactions between, whether you're hungry, full, and different sort of cravings. And really humans will tend to get as much sugar as they possibly can. And so I think that's something that comes into the Western civilization a lot, where we see much higher levels of diabetes. And it kind of plays into that lecture that you guys had on the cultural impact of diabetes. And diabetes is such a, like broad disease in terms of influence on someone's body that, yeah, all of these different cultural, behavioral, emotional, lifestyle factors all play such a huge role. But essentially what the human is doing in a very, very basic physiological sense is trying to get as much sugar as possible, trying to get that absorbed into the bloodstream so that it can be given to the brain for energy. I'm sure you guys have seen that saying that like the body's purpose is just basically to move the brain around the world. And essentially that's what the brain thinks. So the issue is that this needs to be really tightly regulated. So you're okay if you're between 3.3 and 6 blood glucose, but if you go too high or too low, then you can reach areas where you actually have dangerous manifestations and complications of having your blood sugar too high or low. So then the question is how does the body regulate this then, right? So it uses a really complex multi-organ system with many different hormones that communicate, to help control and regulate this thing. This is a really tight regulation and a really, really robust system. So what do we have? So what are the constituents of this? So not only does your brain, need glucose to function and preferentially use it as its energy source, it also can use it for other things. So the big value of glucose is this ATP down here. So obviously your brain uses it for energy, but there's all of this unlocked potential for other tissues to use glucose, right? And your body does this for a reason. It blocks it off from going other places that is not as important, and it preferentially gives it to the brain firsthand. So this way it's blocked off. And then we have a couple of organs that are really important in the regulation. So first we have the kidneys here, and we'll start there. And kidneys do have a form of what's considered gluconeogenesis. Essentially what it is just reabsorption of filtrated sugar. So that sugar goes through your glomerulus, goes into that filtrate, and your body goes, I'm not wasting that. I don't want to pee that out. I need all of that back to go to my brain. And it uses a transporter called SGLT2 to do that. Next, whenever you have excess glucose in the bloodstream, this signals to your liver to start making glycogen. Again, this happens through many complex hormonal pathways to help regulate how much glycogen is stored. But essentially with extra blood glucose, if your brain is satisfied, you'll also get a smaller proportion of that glucose going through GLUT2. And so it's a smaller proportion because the transporter is lower affinity. And so what you'll see once you get that glucose going through the GLUT2 transporter is deposition of glycogen storage. And if things get tough and all of a sudden you're low on glucose, your liver is really smart and it can actually mobilize this glycogen through gluconeogenesis and increase your blood sugar to help feed back towards your brain and help maintain that really important system of sugar coming in and feeding your brain. The other thing that happens is your pancreas senses how much blood glucose you have, and it does it through the exact same mechanism that the liver does this. So it has a transporter that's low affinity, and essentially it tries to sense or approximate within its own cells what the blood glucose is. So as we have blood glucose go up, we get more pancreas stimulation through the GLUT2 transporter, and then the pancreas responds. So what's the job of the pancreas then? So it's a bit of a dead end and a mystery here. So without further ado, we'll reveal that. And essentially the biggest thing that the pancreas does is it releases insulin. So the insulin is the key hormone regulator of blood glucose. So first of all, what it does is it's a key. So it unlocks GLUT4 transporter to cells like adipose tissue and muscle cells and other cells of the body to have this huge boon of energy and do a lot of cellular function with that glucose that you have. So this insulin is facilitating other functions outside of that bare minimum brain function that is always going on because you really want to protect that brain. So it gives you opportunity to do more things with more energy in different tissues. What it also does is it says, okay, we don't need to do gluconeogenesis. And the reason for that is because we have enough blood glucose. So we've just had a nice influx of glucose through the GI tract. We don't need the liver making anything extra, okay? The other things it does is it inhibits other less efficient forms of making energy. So let's say you're really, really hungry, but your environment just doesn't allow you to bring in any extra glucose. What it needs to do is it needs to mobilize glucose from the liver for your brain, and it needs to mobilize alternative resources. So insulin is released in a situation where that's not happening, where you don't need those alternative resources. So you don't need to break down fat, you don't need to create ketones, and you don't need to do proteolysis. And you see it preferentially chooses that because the ATP that those processes make is quite small in comparison to the APT potential of processing glucose in the cells. Okay, so I hope everyone's following me. If there's anything on these slides where you guys are like, you missed talking about this, I don't quite get what you mean with that, just pull it up. The other thing is that physiologically, insulin is a pro hormone. And so it's a pre-pro hormone, I believe. So it's processed twice, but one of the metabolites of processing is this C peptide, which is basically, doesn't have any physiological function, but it's a leftover of insulin becoming active in the body. Okay, so it can be a test that we can test in blood work to see how much insulin is that pancreas creating, and as a byproduct creating C peptide. So that's one small piece. So next is within this tight regulation, even within that, there's a certain category that we call pre-diabetes, and I've just defined it here for you. So that's when people start sneaking up to the higher end of what we would consider normal. And really the big thing to take home here is that as much as we define normal in these really strict thresholds, both in hyperglycemia and hypoglycemia, it's all relative. Different people will have different fasting glucoses dependent on the variation of all their different genetics that's going on within this mechanism. So again, there's incretins, which are the hormones that come from the gut. There's hormones coming from the brain. There's hormones coming from the liver, hormones coming from the pancreas, from the kidney, and all of these we don't fully understand, but you can get into those nitty-gritty details, and there is some sort of interesting opportunities for therapeutics within those, but we don't need to go too deep into those at your guys' level. Okay, so next we'll jump into it. I'm just going to take 1 second. I just have to grab something. Okay, sorry about that. So next, I just want to make sure. It looks like, do we have a question here? Okay, really cool / fun slides. Compliments are much appreciated. Thank you so much, Moise. I hope I'm saying your name right. So next, what we're going to do is talk about, okay, so what happens when things go wrong? What happens when that blood sugar goes really high, which naturally does happen, right? You know, we can't tightly regulate everything to the unpredictability of life and when we get food into our system, right? And that plays a big role in diabetes control as well. But that's just a natural part of the human condition, is that when you find sugar and you're hungry, you're going to eat as much of it as you can possibly tolerate. And then you're going to hope your pancreas can react to control that. So what happens with insulin is that it's released when you go hyperglycemic, okay? So you get more stimulation sent through the GLUT2, which I have here, and you get improved function and release of insulin. So synthesis, how much insulin do you have, is one big factor. And it's not only affected by just what your pancreas senses and is doing, but there's also other factors like exercise. Obviously, when we're using exercise, we need a lot of energy for our muscles. So the autonomic nervous system is going to release those catecholamines, and those catecholamines are going to help release insulin to help compensate and maintain good energy flow from your bloodstream into those cells and muscles, and you're using it. Synthesis decreases with age. This is a key concept. I always tell patients that if we all lived to 200, we would all have type 2 diabetes. I have no idea if that's true, but I think the concept holds true in the sense that that your ability for the pancreas to release insulin decreases with age. I have a quick question. Do all blood glucose tests have to be repeated if there are no symptoms? If so, can you confirm why? So we'll kind of get into this a little bit. You know, the main thing is that blood glucose can be a cause of severe symptoms, but can also be related to other severe medical comorbidities that are going on at that time. So to say that there's a blanket statement for if someone's blood glucose is abnormal and they have no symptoms, it really depends on what exactly that blood glucose is, what symptoms they may have, what other information you have available clinically. But you do, in general, have to ask yourself, do I trust this blood glucose? Does this make sense and fit the pattern for what I'm seeing? And it's such an easily, readily available test that really getting another test to confirm things and monitoring over time and seeing the natural progression and the natural progression of what's happening with the blood glucose is super helpful clinically. So good question. But definitely what you can say is that blood glucose tests are fairly reliable and just ubiquitous. So if you're ever questioning, hey, could blood glucose be a complication of what I'm seeing? Could it be the cause of what I'm seeing? Go ahead and get that blood glucose. It's listed as the 6th vital sign along with like 5 other things depending on your specialty. But I think it is truly a good contender for that 6th vital sign. Okay, so you have the synthesis of insulin. And so that goes down over time. You know, it increases when you have blood glucose that comes in through the stomach or when you're exercising, you need to mobilize extra energy. Then the other thing is how potent is that insulin? So one, obesity and the hormones that are released from adipose tissue will change and decrease your insulin sensitivity, make you more insulin resistant. Again, your insulin potency, so your resistance to insulin, actually increases with age. So potency decreases with age. And then the other thing is that the higher your blood sugars are, the less of an effect insulin has. So the more sugar that's in the bloodstream, the more insulin relatively you need to have circulating to help signal that GLUT4. And I'm not exactly sure why that happens, but it's a common effect, especially with new presentations when blood sugars are very, very high. It takes a ton of insulin to get those people well controlled. And then you can slowly pull off the insulin once you start measuring the blood glucoses more long-term and titrating more tightly and over more of a long term. Okay, so what happens when you go low? So when you go low in blood glucose, you have counter-regulatory hormones that happen. And there's a few major ones. Sorry, I'll just make sure you guys' mics are muted. I can just hear some of you. So The counter-regulatory hormones, like the big ones that you have to know about, well, first of all, is glucagon. So glucagon is basically the counterpoint to insulin. So if you were to reverse these stop signs into go signs, and you reverse this go sign into a stop sign, and you put glucagon there, this would be a fairly good representative diagram as well. And so that's created by pancreatic cells as well. So it's interesting to think about glucagon and insulin together because they're the key modulators of blood glucose titration and regulation. So something that happens and that we see all the time is that people who are predisposed to having issues with their pancreas end up getting diabetes and end up getting a propensity to become hypoglycemic as well. And that's probably because they have impaired glucagon and other signaling functions as well. So when we're focusing in on the pancreas, particularly, for example, someone who has, say, chronic pancreatitis or recurrent pancreatitis, and that's the cause of their diabetes, which is one of the more common secondary causes of diabetes, and we'll get into those in a second. But when that happens, not only do you lose insulin function, you lose glucagon function as well. So you have a propensity and a higher risk to actually fall into hypoglycemia. And that's why hypoglycemia is really, unless it's secondary to something that's quite rare or a medication, it's almost exclusively seen in diabetic patients. So if you're seeing someone who's hypoglycemic and they don't have a diagnosis of diabetes, they either have one of those rare secondary causes, or you need to test them for diabetes. Okay, maybe do both. And then the next one, so not only is glucagon a good counter-regulatory hormone, but there's backups, there's fail-safes. And that's because hypoglycemia, like you're hanging out pretty close here, right? You're trying to reabsorb things, but if something goes wrong with the kidneys and you start losing glucose out here, you wanna be able to have a robust response to bring up that blood glucose. So the other ones, these backup ones, is cortisol. And when you think about cortisol, so cortisol is basically a stress hormone. So it reacts to all types of stress and mainly physiological stress. So we can give someone cortisol in supra-physiologic levels, which would be therapeutic levels, that causes the immune system to be reduced in autoimmune diseases. So iatrogenically, we can induce hyperglycemia in those. Classic example is these really bad vasculitis ones, where you give people called pulse steroids. So these are massive doses. You know, when we're thinking about giving someone like 100 milligrams of prednisone a day, that's like really high dose oral steroids. These pulse steroids are like 1 gram a day of methylprednisolone, which is equivalent to prednisone PO. So we're giving people these massive doses that can definitely be enough counter-regulatory hormone to push someone into hyperglycemia. The other thing is in those physiological stresses, infection, or if you're inappropriately endogenously making, so Cushingoid or Cushing syndrome. The other thing is growth hormone. So if you see signs of acromegaly or growth hormone excess that's inappropriately made, then you can also see hyperglycemia. And then epinephrine, and this makes sense, right? Epinephrine, again, is one of those hormones that's released when you're, say, exercising, part of that autonomic sympathetic response, and that'll raise your blood glucose. And the reason for that is because they know that you have insulin release. So your body will have insulin release during exercise, will be pulling a lot of glucose out of the blood to the muscles to use as energy. So it also needs some counter-regulatory hormones to allow the blood glucose to be upregulated and increased through processes like more gluconeogenesis through the liver or through the kidneys. The other thing about epinephrine is that it's not only released based on physical stress like exercise or illness, but also emotional stress. So people can have raises or increases in their blood glucose due to emotional stress as well, but it's not something that's typically persistent or significant enough to cause a diagnosis of diabetes, but can cause an effect in a diabetic for sure. So basically what's happening is you're having this complex interplay between insulin, which is the most important factor, bringing down your blood glucose, allowing it to be utilized, and inhibiting these less efficient pathways, for energy production. And there's side effects of those alternate ones, right? Like lipolysis causing ketones and acidosis. So I have a question here, and we're about to move to the next slide. So just to clarify, did you say there's a propensity to get type to get type 2 diabetes mellitus because of these secondary hypoglycemia causes. Sorry, I do not, I don't know exactly what you're asking here. So, so with hypoglycemia, these in the physiological state, these will be appropriately released to combat your hypoglycemia. But let's say you're actually doing quite well and you have enough of a regulatory response to allow yourself to stay in here, but then something else on top of this causes you to have super high cortisol. Like let's say you endogenously create a lot of cortisol and now you have Cushing syndrome. Yes, that can push you from a normal blood glucose up into the hyperglycemic range and meet criteria for diagnosis of type 2 diabetes. The other thing to keep in mind is someone who's diagnosed with type 2 diabetes, so you already have basically dysfunction in this regulatory pathway, you have a propensity to not only have hyperglycemia persistently and chronically, but episodic severe hypoglycemias. So almost exclusively in diabetic patients, due to their medications and dysfunction in this regulatory pathway, do we see hypoglycemia. Okay, I hope that answered your question. If not, just let me know. Great, thank you. Okay, perfect. So we'll move on to the next slide here. Sorry about that. So this next slide is just all about the presentation of diabetes. So particularly in type 2 diabetes, which is by far and away what you'll see most commonly, this is a model disease for screening. So I won't go through all these in detail. In that last lecture on Friday, when we were talking about hypertension as a model disease for screening, the same things apply here. So you have a disease here that progresses slowly over time. It's common, okay? So a lot of people have it. It's silent early on, so people don't know they have it. We have good interventions that can cause improved outcomes, and we can have a good, easy to use blood test like a hemoglobin A1C to find those asymptomatic people. And, you know, what was I saying? I have no idea. Anyways, it's a model disease for screening because it has that period where you can catch people, where you can intervene and make a difference. And because if we didn't intervene, there's so common and there's such severe complications that accumulate over time that we save a lot of quality of life, a lot of life years, and a lot of healthcare dollars by screening for it, okay? So again, the main issue with diabetes is a relative insulin deficiency, period. When you talk about primary diabetes, so when I say primary diabetes, essentially what that is type 1 diabetes and type 2 diabetes. Secondary diabetes would include all of those things like someone's had pancreatitis, someone has a MODY, so a specific genetic variation in one of these regulatory pathways or transporters or hormones that causes them to be hyperglycemic and insulin to not be relatively enough for them, right? All of those different conditions, there's a huge bucket of them. They can all be encapsulated by that person has a relative insulin deficiency, which manifests as hyperglycemia, okay? So that's really why, you know, we need to be able to pick this up in a blood test. And luckily we've made some really effective blood tests in order to pick these things up. So really the diagnosis is all in increased blood glucose. So when you do a hemoglobin A1C and it's greater than or equal to 6.5, that just correlates with a certain blood glucose that we define as above a normal range, okay? The other test that you can do is a fasting blood glucose. And again, that's not quite as convenient for the patient, and there's more opportunity for you to have an inaccurate test, like say someone accidentally ate before it. Or there's the oral glucose tolerance test, can usually pick up, you know, less obvious states of diabetes, say like pre-diabetes is often picked up in oral glucose tolerance tests. There's also a range in the A1Cs that I listed on the previous slide that you can diagnose someone with a pre-diabetes if their hemoglobin A1C is between 6 and 6.4. But the main thing is that you want to make sure this is real. So you get 2 tests, right? But it's a pretty good test, pretty accurate test. Now, what's the exception to this? So the classic person will be someone who comes into your office and they're 45 years old and they were tested when they were 40 and they were 6.1, so in the pre-diabetic range, and then you test them again 5 years later, and boom, their A1C is 6.6. They don't feel any different. They don't know anything is different, but the blood test shows it that on average, they do have elevated blood sugars. Oh, I just realized that I lost the chat, so I'm just gonna pull it up just in case people are asking questions. Okay, awesome. And so when it comes to, you know, the alternative to that, so really the classic alternative to that, so that would be type 2 diabetes, sorry, someone who comes in asymptomatic, their blood sugars have probably been creeping up over time. They have a relative insulin deficiency, which hasn't manifested any complications or symptoms due to the high blood sugar. Now, as your blood glucose gets even higher due to having an even more profound lack of insulin, this spectrum, we start approaching towards the classic type 1 diabetes presentation. So type 1 diabetes is an autoimmune attack of the beta cells in the pancreas, so you don't make any insulin. When I say that, I mean it's a much more drastic drop off. So lots of patients in type 1 diabetes can still present with some insulin and not in DKA, and that's why not all of them do present in DKA, but the classic patient has complete loss of beta cell function and synthesis. And so they have an absolute insulin deficiency. And we'll get into the reason you see these differences later on when we talk about hyperglycemic emergencies. But essentially what happens is when you have a complete lack of insulin here, you cannot inhibit lipolysis and you cannot get energy from insulin into the cells. So you get lipolysis going, which creates ketones, which is an acid. So you get acidosis. And you get this really high blood sugar getting backed up because your brain just can't use it all. So a couple of things will happen. First of all, your kidneys get overwhelmed. So this gluconeogenesis or reabsorption through SGLT2 in the kidneys can no longer happen as soon as your blood glucose goes above 11.1. So as soon as you start losing glucose into your urine, you also start losing other electrolytes in water. And that happens because glucose is an osmotically active substance. So when you get extra osmoles into your urine, into the filtrate as they're going through the nephron, they will pull along with it extra ions, extra water, and you'll get an osmotic diuresis, okay? So these together, the lack of energy and the loss of water, glucose, and ions in the urine is what causes the symptoms. So loss of energy, people will often say that they're constitutionally unwell. They have fatigue, weight loss. They're eating more and more. They're starving, right? They're losing all that glucose before it can get to the brain, and their brain is starving for that glucose based on it being told by the muscles and other cells that aren't getting it. So will someone with type 1 diabetes always have glucosuria when blood glucose is greater than 11.1? So excellent question. Typically, yes. So obviously this threshold varies on individual genetics and physiology, but in general, once you get a blood glucose above 11, that's when people become symptomatic, and they become symptomatic because it overwhelms their body's ability to hold on to their glucose and utilize it properly. So it's kind of like this threshold that you should keep in mind. And that's why some of the diagnostic criteria is like a random blood glucose or an oral glucose tolerance test above 11 is considered abnormal and diagnostic for diabetes. Sorry, one more question. Sorry, just to clarify, for screening, would you order A1C plus random blood glucose or just A1C to start? So if you're screening someone, you would only order A1C, but let's say you're thinking that, basically you would only order one. And so I'll get into why in a second. So the only reason why you would want to get 2 blood tests faster to confirm high blood sugars is to make the diagnosis, because technically you need 2 to make the diagnosis. So in place of having that second test, you can also have symptoms. And those symptoms are meant for people that do have really high blood glucoses, right? And that's classic, or more likely to happen, I should say, in type 1 diabetes, okay? And so often they'll show up, they may have acidosis, they may have ketones, And those will make someone very symptomatic, and we'll go into those symptoms now. But purely from a hyperglycemia, lack of insulin standpoint, people will get the symptoms of fatigue, weight loss, polyphagia, that's not having enough energy that they can utilize, and then polyuria and polydipsia due to that osmotic diuresis. And there's a few other things that you would just generally look at just in terms of general risk for diabetes, as well as for things that are specific to diabetes. So acanthosis nigricans, the darkening pigmentation on the neck, a skin finding is associated with insulin resistance. And then there's NLD, which is associated with diabetes itself. And of course, looking for secondary causes. Most people, like I said, in the model of type 2 diabetes, you'll find them. They'll be having risk factors like obesity for diabetes, maybe a family history, because it's quite strong genetic predisposition for type 2 diabetes. Most often there's nothing defined that's causing their diabetes. It's a primary cause, a primary type 2 diabetes. Okay, we have some good questions, and these will be helpful to highlight some key points probably. Okay, so if that is the case with someone with long history of type 1 diabetes, say many years, end up with complications of ongoing glucosuria in their urinary tract or elsewhere, see if they're having blood glucoses above 11 multiple times per week for years. So there is other complications to having this glucosuria, and one of them is urinary tract infections, because glucose is good energy for bugs as well. Now, it all comes down to if someone is symptomatic, what that means is likely that their blood glucose is persistently above 11.1. So if that's a type 1 diabetic, that's a poorly controlled type 1 diabetic. But if they're poorly controlled, then yes, they would have glucosuria, the symptoms of polyuria and polydipsia, and potentially complications of that, like frequent UTIs. Okay, so good question. Since GLUT3 is high affinity and you have hyperglycemia, how come it doesn't cross into the neural cells? So it does. And what you can get as a side effect of really high blood sugars is actually edema in the brain. And that edema can lead to neurological symptoms like confusion, altered level of consciousness, weakness, coma, even death. That might be the mechanism how people die from these hyperglycemia episodes and emergencies. That's one of the mechanisms anyway. So really good point. You definitely do get that as a pathophysiological complication. Okay, so basically in the end, when you're making a diagnosis of diabetes, it's all in the blood tests, and it's so common that you're gonna find it if you screen for it. So really what you wanna do is you wanna just generally ask, are you having any of these classic symptoms? So I always ask polyuria, polydipsia, constitutionally low energy or polyphagia, okay, constantly hungry. And then I'll do a quick skin exam, look at their legs, see if, what their BMI is. And that's really it. What it comes down to is getting a hemoglobin C above 6.5 or equal to it, having symptoms plus a random blood glucose on the spot that's greater than 11, or alternatively doing the fasting blood glucose. Okay, so those are the different ways you can diagnose it, but really it just comes down to that blood test. Okay, so I hope that makes sense. We're going to move on to the next slide here, which is essentially just a slide again to kind of talk through some of these concepts. So really what we're doing when we're screening is we're trying to capture someone along this pathway. So as you can see, diagnosis happens after the pathophysiological processes have already begun. So as I said before, as you get older, your beta cell function, so synthesis of insulin, goes down. And this is just part of the human condition. So it goes down over time. Now, obviously the rate at which this goes down is purely genetic. Some people have super fit beta cells and they maintain this for much longer. And so they'll never run into issues with a relative insulin deficiency, okay? Now the issue is that acting against insulin is also your insulin resistance, which again increases with age, increases with obesity, which we tend to get more obese as we get older. And eventually you reach this critical threshold where you have a lack of insulin and enough insulin resistance where you will actually start getting increases in your blood glucose. So that pre-diabetes can be kind of split into two different variations. One is a high postprandial glucose, and the other one's an impaired fasting glucose. And typically, what stresses that regulatory system that we just went through is those big stresses of a bunch of glucose coming into the system all at once. And so when that happens, you're more likely to catch those people earlier on. So that's why before this actual diagnosis is made on this slide here, to the left of it, we could probably catch people a little bit earlier if we did those oral glucose tolerance tests. We don't do that basically because the hemoglobin A1C test is so convenient and easy to do, and it catches people early enough where we can still make a difference. Now, the difficulty is as people progress from pre-diabetes to type 2 diabetes, so does the complication silently of diabetes. So often this is an asymptomatic, insidious disease that develops over long periods of time. And as you can see, after the diagnosis, things don't get any better. Beta cell function continues to worsen. Insulin resistance probably actually even goes up, because remember, as your blood sugar goes up, insulin resistance goes up as well. So you're definitely going to be seeing more and more needs to help supplement insulin. So you're going to be needing more medications, right? You're going to need more intensive lifestyle interventions. So when someone is diabetic and they lose, 30 kilograms and they're no longer technically diabetic based on the blood tests, it's a bit of a ticking time bomb. And that's the same concept that happens with gestational diabetes. Gestational diabetes is a warning sign, because what you're doing is you're creating an insulin resistant state to stress your beta cell function. And you're seeing, hey, where am I at right now? So you're kind of trial by fire, seeing where your beta cell function is. And if it proves to be not adequate, well, later in your life, you might run into an instance based on other factors like obesity and age, medications, counter-regulatory hormones, etc., where your insulin resistance is high enough where you will again become diagnostic based on blood tests for diabetes. Okay, so I think that's everything I want to touch on this. I see we have one question here. So this is a question about type 2 diabetes symptom presentation at very high blood glucose. Is oral thrush something you've ever seen in your practice or heard of? So diabetes, and we'll get into this when we go into the complications, but diabetes is an immune suppressing state relatively. It's not like the most profound immune suppressed state, but it is generally an immune suppressed state. So you're more likely to get infections, particularly infections on surfaces of the skin or oral or mucosal surfaces. So vaginal infections like vaginitis, UTIs, candidus infections of the skin, candidiasis infections of the tongue. All of those things are definitely possible, and you're at a increased risk of those when you have diabetes diagnosed. And it probably correlates with the severity of your hyperglycemia for sure. Okay, so let's go into management then. So we've picked out, why diabetes happens, what are the risk factors, what are the physiological parameters that control it. We've gone through how to diagnose it, right? So it's basically, most often it's a blood test, so screening the right people, okay? And then it's making sure that this is sort of typical type 2 diabetes and making sure there's no obvious secondary causes on history or exam. And those are tough to pick up, but you can pick them up every once in a while. And often they're just contributing factors. And then we also went through, okay, what about the other symptoms? And that's usually happening in a more severe presentations where there's closer to an absolute insulin deficiency, say like in type 1 diabetes, where people have the symptoms of hyperglycemia, polydipsia, polyuria, polyphagia, constitutionally unwell, okay? And they can present in the extreme of that, which is diabetic ketoacidosis, which we'll go through in a second. So now you have this person, and again, in terms of long chronic management is what we'll focus on here. So basically what you're doing is you have to sit this person down and do what I just did. So diabetes is super complex. There's a reason it takes a multidisciplinary team and it takes dedicated diabetic educators to get people to properly and appropriately manage this disease. Basically, you're saying you need to have your life super organized in terms of diet, exercise, here's medications on top of it, here's a couple visits to specialists. Oh, by the way, you can have acute life-altering, life-risking complications, and here's how you can deal with those. your life is going to be potentially significantly shortened by this disease. My point is, it's a lot to take in, right? So I want to simplify it. So from our perspective, we're educating this patient, but also what are we trying to do? So basically what we're trying to do is we're trying to reduce the risk of end organ damage. The same thing that we're trying to do with hypertension and other cardiovascular risk factors. And so that's part of it, right? Is you have to search out and you have to aggressively treat their comorbidities that also increase their cardiovascular risk. So one good example is blood pressure. So with blood pressure, our threshold for treating diabetics is even lower, okay? And we have specific blood pressure medications that reduce the risk of specific complications in diabetes, such as diabetic nephropathy and ACE inhibitors or ARBs, okay? So you have to think about those things, but basically that's what we're doing is we're trying to say, based on our understanding of controlling cardiovascular disease, controlling your blood sugar, what are the things that we can do to reduce your risk? So people often get very hyper-focused on controlling blood glucose, but the thing to keep in mind is that glycemic control really has only been shown to reduce the risk of microvascular complications. So when you look at it just generally and you don't look at the specific medications and you compare someone who has pretty good glycemic control and someone who has poor glycemic control, they're not necessarily going to die from heart attack, from stroke more often, but they're definitely going to have those microvascular complications more often. So that's a big piece of it. Now, in terms of microvascular risk reduction, you get a lot more bang for your buck by attacking things like dyslipidemia, hypertension. So you cannot forget about those comorbidities if you want to reduce someone's risk from a macrovascular complication standpoint. And we're going to define those complications here in a second. Now, the main thing is that, again, just like with hypertension, what we're trying to do is balance using medications and drastic lifestyle interventions with harmful side effects. And really the most obvious harmful side effects are those acute massive swings in blood glucose, either up or down, that can cause mortality and morbidity. And this kind of comes out in the literature as well. So the tightest control A1C that we've studied, which is less than 6, actually increase mortality in type 2 diabetes. So this isn't just like a quality of life thing. This is a, potentially life-shortening harmful side effect that we can cause based on our management. So we have to be very careful and we have to personalize this to each patient and we have to make decisions on their care based on what they care about, what they're at risk for, and really what their goals are, okay, long-term. All right, so I won't go through all the different details that people need to be educated on. I kind of highlighted them, but basically a diabetic educator is a must, especially in type 1 diabetes where someone's going to be managing insulin right away. That's obviously a life-altering diagnosis, a massive life-altering diagnosis. So when you're trying to convince people why they should care about diabetes, I think the thing to go to and to talk about is complications. So we're going to talk about that next. And sorry, this just popped up. So typical control, again, 6, too low. 7 to 8.5 is sort of the butter zone. And I'm not too strict about it unless someone either has known or is at super high risk for those microvascular complications, then maybe I'll be pushing things a little bit. And again, they have to be low risk for these acute harmful side effects that can kill people. Okay. So we're going to go into complications. So again, as I said before, diabetes is this huge spectrum of disease in terms of when it manifests, how it manifests, and how severely it manifests. Diabetes is not just high blood glucose. As I said before, the main common pathophysiological concept for all diabetes, no matter if it's primary or secondary, is lack of insulin. So definitely you have that. You definitely have lack of insulin leading to hyperglycemia. But even beyond that, that complex regulatory system that includes the brain, the gut and its hormones, the liver and its function, the pancreas and its hormones and function, as well as the kidney with its hormones and function, all can have sort of these dysfunctions that happen. And it's really complex, and I don't want to go into it, but really what you have is you have a general metabolic syndrome and metabolic dysfunction, which also includes your endothelial lining, so the lining of your blood vessels. And when you have endothelial dysfunction, you get narrowing of your blood vessels, You get atherosclerotic changes of your blood vessels. You get stiffening of your blood vessels. You get propensity to clot of your blood vessels. So all of this leads to vascular disease, either acutely, so an acute presentation of it, or chronically, a chronic presentation of it where it's slowly going down, of poor blood flow and relative ischemia. And that's the cardiovascular disease that you get from it. Now, the other thing to keep in mind is the hyperglycemia itself does cause damage. That definitely plays a role. And there's three main mechanisms which you may be tested on in which it does this. So it directly glycosylates proteins. So when you're directly glycosylating proteins, you can glycosylate them basically randomly. In fact, that's what we're measuring when we measure a hemoglobin A1C. So when a hemoglobin A1C is 6.5%, that means all the hemoglobin molecules in that blood sample, 6.5% of them had glycosylation on them. So this can happen randomly. So imagine if this happened to a really important enzyme or transporter of a cell right at its active site. You know, that can poison the cell, that can kill the cell. Okay, the other thing that happens is because you're not getting energy into the cell, you're not getting those normal glucoses, you get alternative hexose pathways, which degrades your NADH deficient or decreases NADH in the cells, the levels in the cells, and you get a relative deficiency. This is basically an energy, it's like an energy storing molecule. Sorry, it's been a while since I've done basic biology, but it's an energy storing molecule. So lack of that causes oxidative stress. The other thing is you accumulate these alternative energy pathways, which, you know, your body can use other sugars or other hexoses, but they accumulate toxic metabolites and they're not as efficient as glucose, so they can cause damage as well to individual cells. So you get hyperglycemia, basically causing cellular dysfunction and cell death. You have endothelial dysfunction, which causes acute and chronic cardiovascular disease. And these accumulate over time. So the cardiovascular disease in cardiovascular disease means that people usually get cardiovascular disease compared to control about 15 years earlier. So that's quite significant. The other thing is these complex metabolic abnormalities also have other disease manifestations. So relative risk of cancers is greatly increased in diabetes. When I say greatly increased, I shouldn't say the actual degree of increase, but quite broadly, the risk of cancer is increased. Risk of depression, right, and other mental health conditions, autoimmune diseases, right? So there's a gluttony of autoimmune diseases that are associated with diabetes, vitiligo, celiac, thyroid autoimmune disease, et cetera, right? What is the mechanism for increasing cancer? So I don't know for sure, but when you think about it, cancer, so in general, when I think about cancer, cancer is basically a statistical anomaly of an abnormal cell randomly gaining the opportunity to grow independently in the body and create problems due to that independent growth. So it has to escape the immune system. And again, we talked about the immunocompromised state in diabetes, that may play a role, but also as you have cell death, cell dysfunction, cell damage, you can potentially get a propensity to cause more mutations. I don't think anyone knows the answer. You probably have to dig into the weeds pretty deep, but that's how I think about it. So definitely we do see these though in retrospective and prospective studies that there's an increased risk of cancer in diabetes patients. Okay. So one other question, just to clarify, diabetes can be diagnosed with hemoglobin A1C at 6.5, but the targeted control is 6.8. Yes, exactly. So the main thing is you just asked an excellent research question. You know, well, why does that happen? And I don't know why that happens, but what I can tell you is that I know that it does happen because we've carefully observed it in randomized control trials, where if we try to push that A1C into what we would expect to be a normal physiological A1C, we actually increase death. And the reason for that is probably because it's so much more than just what your blood glucose is. It's a complex hormonal metabolic syndrome, which one of its main manifestations is high blood glucose. Okay. So autoimmune compromise is seen in both type 1 and type 2, that's correct. Yes. Okay. So what are these major cardiovascular complications? And we'll kind of go into those now. Um, oh, sorry. Are autoimmune conditions seen in both type 1 and type 2? Much more so in type 1 for sure, but I'm not sure about type 2. It's a good question. Type 1 for sure. Yeah, good point. I don't know. Someone will have to look up if it's associated with type 2. Anyways, the complications that I tell people about that really matter. So some of these you've learned a little bit, so I'm not going to beat them to death. Cerebrovascular disease, right? Coronary artery disease, peripheral vascular disease. These are your macrovascular disease. So again, not affected by hyperglycemia to the same extent that microvascular disease is. So you know cerebrovascular disease a little bit, you'll learn more about it in neurology, but basically obviously an acute presentation of cerebrovascular disease is stroke and a chronic one is vascular dementia. And those would obviously have a huge impact on someone's life and health. Coronary artery disease, you know about well. So you know coronary artery disease itself, ischemic heart disease, and later complications such as CHF from that can all happen and are all higher risk in diabetes. Peripheral vascular disease. Now this one I'm just going to highlight a little bit more because I don't know how much you guys learned about it in course 3, but definitely a manifestation of peripheral vascular disease is erectile dysfunction. So let that be a warning sign to you when you see a patient with that. The other thing is the contribution of peripheral vascular disease to diabetic foot and how important foot care is in diabetes. Like all of these small components make such a big difference in diabetic lives and management. So diabetic foot is often caused due to a multitude of factors, not only macrovascular peripheral vascular disease, but microvascular neuropathy as well. And once these develop, they're really a harbinger of bad things to come. Mortality is 50% at 5 years when someone has a peripheral vascular foot ulcer, okay? And they have a 25% lifetime risk. So that's why these people have to look at their feet so often and why they have to get a doctor to look at their feet so often and why often we use the help of podiatrists to help care for diabetic patients. Okay, and then there's a couple just exam findings that you can look for. Again, when you diagnose diabetes, you want to see that they have ischemic limb changes in their hair and skin, right? So arterial peripheral vascular disease, you'll get that hairless, shiny, thin skin. You'll get like rubor on dependency, etc. So I won't go through all of those things. Okay, we have a question here about erectile dysfunction. Is it always a red flag for peripheral vascular disease in an otherwise asymptomatic patient, or can it be a normal thing with aging as well? So I would say erectile dysfunction is a symptom with a differential diagnosis. And so you should definitely think about the possibility that that person is having erectile dysfunction due to peripheral vascular disease, but definitely there's other causes. Often those causes are things such as emotional or psychological causes that can cause erectile dysfunction. Those are the two big ones I see most of the time. It's a very interesting condition and it's not often brought up with doctors actually. So when you do hear about it, just consider that as well. Sorry, I think someone's like trying to call me or something. I'm just hearing like a random dial tone. I think someone maybe just needs to mute their number. It's just like creating a dial tone for me that I'm hearing every few seconds. 1403 blank 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 335. If that's your number, just go ahead and mute. Yeah, let me figure this out. Okay, here's our first technical challenge. Bear with me, everyone. Feel free to take like a 30-second stretch break. Let me see. Participants. Okay, here we go. I think I figured it out. I've muted them. Very sorry, I did not mean to be happy about muting you, but it was just me being successful with technology. So anyways, peripheral vascular disease is definitely a big one that isn't emphasized enough. And I see terrible peripheral vascular disease that goes completely unnoticed for like decades in diabetic patients. So really think about that one. It's just as important as coronary artery disease and cerebrovascular disease. And again, can lead to things like ischemic limbs that need to be amputated, which just has a huge amount of complications and morbidity associated with it. Now, the big things in terms of microvascular is the retina, the kidneys, and the nerves. Okay, so let's go through these ones in a little bit more detail. detail because these are big ones. So retinopathy, the big thing is that you have to be aware that it's possible. You're not going to pick these up on physical exam with like a yearly fundoscopy. You know, you'll probably get asked about what are the typical fundoscopic findings, and they're listed there. But really, you just have to know that if you don't pay attention to this, things can get really bad in the eye. It's the leading cause of blindness in North America, and we're such a visual culture and a visual species that being or acquiring blindness just seems like such an impactful thing. Now, the other thing is that mainly what's happening again is you're getting this vascular disease in the retina. So again, this is a cardiovascular disease. And what happens is you get poor blood flow, and you also get inappropriate leaking of the capillaries and of the blood vessels in the retina. So you get these cotton wool spots, which is actually little micro infarcts in the retina. You also get a hard exudate of leakiness from the blood vessels. And then you get new blood vessels trying to grow in, which actually block the retina and actually cause the blindness, okay? So that's the general progression and the typical sort of findings you'll see. Now, with the kidney. So this is something that I think you had a specific lecture on, and you'll learn and I think understand it a little bit better, especially once you go through your chronic kidney disease lectures in the coming couple of weeks here. But really what happens is, again, the same microvascular disease where you get narrowing of the blood vessels, general ischemia, inappropriate endothelial response, so endothelial dysfunction, all leads to change in the function of the kidney. So eventually what happens is we actually see an increase in the GFR. So this is the hyperfiltration phase. And you're not going to catch that, at least I never have, but theoretically it's there. Next, that progresses and it kind of recovers back down to normal, and you start getting progressive albuminuria. So it starts with microalbuminuria, which means can't see it, can't smell it, can't touch it, but you can test for it with an albumin creatinine ratio. But that can progress to really high albuminuria, where you actually get something like close to a nephrotic syndrome, which you'll learn about later. Sorry, my chat just disappeared, and I see a question here. Yes, we'll get to neuropathy here, and I'll answer that question. So what happens basically is then from that protein, that's basically another sign of the process going on. But the thing that we really, really care about, sometimes you can be losing so much protein it can make an effect and cause symptoms. But really what we're worried about is the function of the kidney decreasing. It's probably, or I think it is, the most common cause of end-stage renal disease requiring dialysis. So with nephropathy, so it's the most common cause of end-stage renal disease causing dialysis, and that's obviously huge. Like, dialysis is not an easy thing to do. If you guys have end up having a chance to get like some patient presentations on someone who's on dialysis, just like really get, you know, to how that's influenced their life day to day, and it's huge. The main thing to keep in mind is that risk begins approximately 10 years after diagnosis. So this is usually one of those chronic, cumulative, later stage findings in diabetes, okay? And again, is strongly associated with hyperglycemia, just like all of microvascular disease. Okay, we have a couple questions here, and we're just getting into neuropathy, and this one is about neuropathy. So does the 80% at 10 years mean 80% of diabetes patients are further diagnosed with this complication? And can neuropathy be existing without an ability to see it with any investigation? So yes, so neuropathy is most commonly diagnosed clinically, either based on symptoms reported by the patient or based on a foot exam that you're doing yearly, and you're doing the monofilament tests, okay, to see that they can feel it. Yes, 10 years into a diabetes diagnosis, whether it's type 1, type 2, or other, 80% of those patients will have neuropathy. So it's super, super common. How bad is it? To what degree does it affect someone? Does it affect sensory, you know, and cause numbness and tingling, or does it affect sensory and cause pain? Does it affect neuromuscular? Does it affect the autonomic system? These are all within that sort of heterogeneous possibility, but it's really unique to that individual's. And that's something that you can see in a very typical pattern though. So the most common manifestation of neuropathy is that glove and stocking pattern. And usually it's a sensory deficit. So often people will complain of numbness, and that's why it can be associated or is associated with the diabetic foot as well. Because if people aren't sensing where they're getting pressure points in their feet, they're going to rub that skin raw and rub it into an ulcer, a pressure ulcer. And then you have poor blood flow, which means poor healing. You're immunocompromised, so you're more likely to get a secondary infection. This is a classic example of how complications can snowball in diabetes. So someone comes to you and they say, okay, I'm a little bit numb in my toes, okay? And then 2 years later, they can't feel their toes at all, and they have thick calluses that you see there, okay? So you do your best to keep those calluses down. You tell them to check their feet every single day. Then all of a sudden they come with you and they say, I have an ulcer, pressure ulcer right here, okay? Then you try to treat that ulcer with good wound care. It gets infected, okay? Next thing you know, this person shows up in the hospital and they have a skin infection, they have osteomyelitis, they have worsening peripheral vascular disease, and this all leads to an amputation, right? So you can go from someone having, complaining a little bit of numbness, and if you don't address it properly, and if you let things snowball, you can go to someone losing a foot or a leg. And that's super common once you get to the severe form of this disease. Okay, I think that's everything about this. I have a couple quick questions about nephropathy. So would the first sign of kidney concerns in diabetes be microalbuminemia and not the hyperfiltration? The first sign in a textbook is hyperfiltration. The first sign in real life is microalbuminuria, okay, for sure. Is it 10 years for nephropathy risk in both type 1 and type 2 diabetes? Yes, it is. So type 1, about 10 years after diagnosis, they should be starting to be tested for this because it's possible for it to begin. And then again in type 2, and it's the same number, and you'll see that in your lecture slides that Dr. Bass had as well. Okay, so I think we're gonna move on to the next slide here. And so this is, we just went through how people can present in terms of screening their blood glucose being high. People can also present with these complications, okay? They can present with a stroke and then they're tested for diabetes and they have it. They can present with a heart attack and they can be tested for diabetes. They can present complaining of glove and stocking neuropathy and you can test them for diabetes and they have it. So these are all possibilities. So next, what we're gonna go through is the emergent presentations of diabetes. So again, this is on the extremes of hyper and hypoglycemia. So we're gonna quickly go through the general principles of hyperglycemic emergencies. And there's two flavors that you have to remember. What I would say about these emergencies in general is that you don't have to know the nitty-gritty management and the nitty-gritty presentation in terms of signs, symptoms, everything that's possible. These are easy diagnoses to make. Your blood sugar is high, okay? There's one exception and it's incredibly rare. And those are people that are on SGLT2 inhibitors where they get the euglycemic, so their blood glucose is normal, but physiologically, they're still in diabetic ketoacidosis. Okay, so one exception, but in general, someone is in the emergency department not feeling well and their blood sugar's high, that's gonna be DKA/HHS until proven otherwise, right? You're gonna treat them like that until you prove that it's something else and that blood sugar is actually secondary to something else that's going on, okay? So these are relatively easy diagnoses to make, okay? Now, there's these two flavors because there's these two different physiologies that happen in these two states. So really what happens in diabetic ketoacidosis is you get a severe insulin deficiency and or an acidosis, okay? I mean, I should say and an acidosis in the name. So you definitely have acidosis. So you have both of those things going on. Now, what you have to remember is sometimes people have an initial insult that causes acidosis. So I believe you guys are going to learn about your metabolic and your respiratory acidosis in detail later in this course, but really big and bad things that cause extreme physiological stress can cause an acidosis. So having a heart attack, having a stroke, having sepsis from an infection, having an intra-abdominal problem like appendicitis, like an acute abdomen, ingesting certain medications or certain substances, or withdrawing for certain substances can all cause that acidosis. If you have someone who has an insulin deficiency that's severe and an acidosis, you're going to have those two problems snowball, because an insulin deficiency will directly drive the acidosis. Remember, if you don't have insulin, you don't have lipolysis inhibited. That means ketones are being made to feed the brain. Brain can survive on ketones. It's the only other thing other than glucose, but it much prefers glucose. And those ketones are acids, so they create an acidosis. Now, okay, so who are the people that are at risk of having an acidosis? So they're sick with something else. These are these triggering events, or they're at risk of having severe insulin deficiency. And so those are really your type 1 diabetics, okay? It can happen in type 2. Let's say someone has really advanced type 2. They're quite old. They've had it for a long time. That beta cell function has just been going down, 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 where they barely have any. And they're old. So all of a sudden they have a myocardial infarction, okay? They can present with an MI in DKA. That's totally possible. And the complex genetics just means some people have more of a propensity for that acidosis to start at a lower threshold, okay? So let's go through DKA in general then. So again, this is a severe insulin deficiency. So they're probably quite hyperglycemic. They're probably symptomatic from that. And then they're also quite acidotic and symptomatic from that. So they don't look well, okay? So they show up to the emergency department for good reason. And then the ketones and acid, the ketone acids, cause some symptoms themselves specifically. And these are quite specific to DKA. So if you see these, you should definitely be thinking DKA in the setting of a high blood glucose. So fruity breath, Kussmaul rest, right? You're trying to blow off extra acids. You're blowing off CO2, which is an acid, to help combat that acidosis. You get nausea and vomiting and abdo pain due to the acidosis. Okay, that's an effect that it has on the GI system. And then you have potentially other symptoms and signs of whatever the trigger is, right? So if this person comes in unwell, fruity breath, Kussmaul rest, they're throwing up, they're nauseous, vomiting, and they have severe chest pressure, and that's radiating down their arm, and they're also short of breath, that's an MI with DKA until proven otherwise, and that's how you have to treat it, right? Okay, so those are like the general presenting features of DKA. So what happens in HHS? So when you're building your classic patient, this is more so the type 2 diabetic, all right? And this is the person who does have an insulin deficiency. That's how they start getting their blood glucose going up, but then they have a second hit. And that second hit in general can basically be considered dehydration, okay? So people who have type 2 are generally older. They generally have renal disease or cardiovascular disease, which when you think about renal disease, one of the big jobs of the kidneys is to get rid of extra fluid. And the heart also can have trouble managing extra fluid when it's in disease states. So this is basically a distribution of water and volume problem exacerbated by getting dehydrated. So a classic story would be like a very elderly type 2 diabetic who all of a sudden has some sort of like mild illness. Let's say they have a gastroenteritis. So all of a sudden they're not eating anything. They feel terrible, so they're not getting up to drink or eat. And they are vomiting and having diarrhea, so they're losing extra fluid. That would be sort of a classic history, but it can be as simple as, missing their diabetes medications and allowing their blood glucose to get to that certain threshold where they'll dip into this hyperosmolar hyperglycemia syndrome. So often what happens is that these older individuals will end up getting really high blood sugars, and those blood sugars will cause, again, as secondary effects, polydipsia and polyuria, sorry. They're usually too sick to drink or too old to immobile. That's sad but true. It's very common. And they also have this polyuria, which is exacerbating their dehydration. So these people get super dehydrated. That really is their biggest problem. they have a relative insulin deficiency to varying degrees, and then they get super dehydrated. They have an osmotic diuresis, which just further perpetuates the problem, okay? Now, often these people come in with a really insidious onset of symptoms, and they're often confused. So you often can't get a great history from them. So when someone has like these, you know, vague sort of neurological things like confusion, altered level of consciousness, they have a high blood glucose, they look hypovolemic on exam, you have to rehydrate that person and think that they're in some sort of HHS, okay? So when it comes to investigations, really there's a couple things that we're doing. We're making the diagnosis, right, which is essentially blood glucose and electrolytes. And the reason that we do that is we want to see what is the relative increase of blood glucose. So in HHS, it's much, much higher. And the reason for that is probably because of the acute progression and presentation in DKA. So HHS, they stay at home, they slowly and slowly get more and more dehydrated. Their blood glucose slowly and slowly goes higher and higher and higher, and that accumulates. As your blood glucose gets higher, remember, you have less of an effect of insulin. Okay, so these people just get to this point where they just teeter, where they can't control their blood glucose at all. Okay, in DKA, these people have an absolute insulin deficiency, but lipolysis starts right away. Ketone production starts right away. These people show up within a few hours. So they don't show up or allow themselves to have enough time for their blood sugars to get super, super high, okay? Now, serum osmolality, which is essentially basically how dehydrated you are, you can bring down your serum osmolality by chugging a glass of water. So that's something they cannot do. So in HHS, that dehydration drives that serum osmolality much, much higher. In general, you'll see the same trend in terms of elevated serum osmolality and elevated blood glucose, but it's different the degree to which they're elevated between HHS and DKA based on the physiology. Now, that's not super helpful, right? Because they both go in the same direction. So the things that are specific for DKA would be the acidosis, right? So you find those ketones, right? You can measure them in blood. Beta hydroxybutyrate is a blood test where you test for ketones. You can test it in the urine as well, very convenient clinically. And then what you'll see in the electrolytes is that acidosis, that anion gap. And that just means the equation for an anion gap is sodium minus chloride and bicarb. So if that's greater than 12, you know there's an acid in there. And you're going to learn why coming up here, but you just have to trust me for now. Sorry. And so you'll definitely see that acidosis specific to diabetic ketoacidosis, and it's caused by those ketones, which you can test for. The other thing is when someone shows up in one of these emergencies, you got to think, man, are they showing up because they're a type 1 diabetic first presentation, especially if they don't have the diagnosis? So some additional tests that you can help identify type 1 diabetes with is looking for antibodies. So it's an autoimmune insult of the pancreas. So you can find many different types of antibodies. The more antibodies you have, the more specific they are against the pancreas and the beta cells, the more likely that this is type 1 diabetes. And then also, if you don't have insulin being produced by your pancreas, you'll also have a very low C-peptide, because remember, that's a byproduct of endogenously created insulin. Okay, so that's important to remember too. So let's get into treatments, and really all you have to remember is the general trends of treatments. And then we'll answer a couple questions that come up on the slide. So in general, both of these are emergencies, appropriately so, because they kill people, okay? Mortality is not insignificant. Remember, hyperosmolar hyperglycemia syndrome happens in older individuals with comorbidities. So of course, their mortality is higher. Okay, that doesn't necessarily mean that this is a worse disease. It's just a sign of the population that it more likely happens in. Okay. Now, what you want to do is you want to treat the physiological abnormality. So for DKA, it's insulin. That's why number one, insulin. You also do have some dehydration, so you're going to give some IV fluids, and you're going to replace a couple of things that the body is losing. So remember when I said before, when you have a osmotic diuresis due to hyperglycemia, you're losing water, so you're gonna need some IV fluids in general. You're losing sugar, okay? So actually, not only is this an insulin deficiency, it's a sugar deficiency. So sometimes you have to give them sugar as you're giving them insulin. And then you also lose electrolytes. And really the most dangerous electrolyte in the short term to lose is potassium. So you will have to replace potassium because their total body stores are deplete. And as you give insulin, you'll learn about this later on in the course as well, you drive potassium into the cells and lower the serum potassium that you see on the tests. So you got to chase that potassium and make sure it stays normal. Now, the other thing, so you're treating the physiological deficiencies that you have. So low insulin, giving that, low sodium and water, so giving some saline, low sugar, so sometimes giving sugar if needed, low potassium, so giving that if needed. The other thing is these people show up really sick really quick for a reason. So you have to think about, is there something else that made them show up so quick? Is there ischemia going on in the brain, in the heart, in a limb? Is there an infection going on in the lungs, in the stomach, in the bladder, on the skin, in the brain? Is there an intra-abdominal problem, like an acute abdomen, like appendicitis, cholecystitis, acute obstruction, right? Have they been ingesting meds? You know, have they been ingesting things like prednisone? Have they been ingesting substances? You know, we will often see type 1 diabetics represent after substance use, things like cocaine, methamphetamine, opioids, either from the withdrawal, the physiological stress of withdrawal, or the substance itself will cause that acidosis. And then secondarily, that may mean that they have poor compliance to their medications and they have a severe insulin deficiency because of that as well. That's a pretty classic presentation, but you have to search for that reason, okay? You have to seek it out. Now, with HHS, in terms of treatment, again, the mortality is quite high because of the comorbidities. Essentially what you have to do is you have to rehydrate these people and you have to try and treat any cause there might be for the reason that they got so dehydrated. Sometimes it's not obvious and it's honestly just due to their functional status and their comorbidities being so advanced, but you start with IV fluids and you continue IV fluids. At some point, you may want to lower their blood sugar, but it's not a priority in their treatment, okay? The only other thing I'll add with hyponatremia, which you may have learned about already, I believe, when you're treating it, do not overcorrect it, okay? So you regularly need to repeat the labs, okay? So when you're looking at the investigations here and the things to make the diagnosis and then to monitor the complications like these electrolyte abnormalities and how fast they're changing, really what you have to do is you have to get investigations every 1 to 2 hours. So initially when someone comes in, especially if they're looking quite sick, like say they're in DK and look quite sick, a blood gas is probably the easiest way to get all of this information, right? You get their hemoglobin, you get their calcium, you get their potassium, you get their sodium, you get their blood glucose, you get their serum osmolality, you get their pH, get their bicarb, get their PaO2, you get their PCO2. It's super helpful. Now, going forward, when you need blood every hour or two, you can transition to just looking at electrolytes. So monitoring the sodium and the potassium through serum blood work. And then that also can give you the anion gap to help monitor how their acidosis is doing. Close the gap. That's the number one thing with DKA is you keep giving insulin because the number one thing that they have is a severe insulin deficiency. And if you give that, that closes the gap, that stops their acidosis, that improves them, okay? Okay, I have a couple questions here. So would steroids be one of the more common drugs in type 1 diabetes DKA cases? Definitely can be, you know, typically when someone started on a medication like that, people are very cautious. So it's not one of the most classic presentations, but definitely theoretically can be one and has been seen before, I'm sure. Okay, for the blood gas and DKA, how often would this be done through an ART line or a venous line? So in terms of an ABG versus VBG, there's a couple big differences. They give you pretty much the same information, but the ABG in a couple of parameters is more accurate. So specifically, that's your arterial CO2. So your PaCO2 is much more accurate. And then maybe your pH is a little bit more accurate. Now an ART draw, so an ABG, an arterial blood gas, needs to be drawn by an RT, and it's quite painful for a patient. So, you know, if this is someone who's going to ICU, you could put in a line in their arterial line, which measures their blood pressure, allows easy draws for arterial blood gases, and that might be reasonable. But more often than not, we can do a venous blood gas which gives us the information much quicker than a serum test because it doesn't have to go down to the lab. They basically run it through a machine, the RTs do. So you get the information a little bit quicker. So if they're sicker, you might go for a blood gas. And if you don't really care much about their PaCO2, then you can probably do a venous blood gas and save them getting a painful arterial poke or arterial line. It's one of those nuanced questions that you'll kind of figure out as you go through clinically. There's no right answer, but basically you want to do the test that gives you the information you need as fast as you can without causing as much impact to the patient. Okay, so often someone's not that sick, but you're worried about, say, some DKA or acidosis that's going on. You might get a VBG. Someone comes in and it looks like they're going to ICU. Yeah, you might put an ART light in and get an ABG to start things off with. Good questions. Okay. So next is hypoglycemia, and we'll go through this quickly. I know that we're approaching 7:30. After that, I have only a handful of slides, so maybe we'll take like a 5-minute break after this slide, and then hopefully we'll be finished up by like 7:45. Okay, thanks for hanging in there, people. So hypoglycemia, really, these sort of little simple principles are the main things. So how do you find it? So there's a triad for it. Think of this as like the anginal triad, you know, where it was like you had classic symptoms that happened on exertion. So this is an ischemic heart disease. So your angina would have classic symptoms that happen on exertion. You would have resolution of those symptoms either with nitro or stopping your activity, okay? And what was the third thing? Oh yeah, and it's triggered by activity. Okay, so classic symptoms triggered by activity gets better with stopping the activity or nitro. So this is another one that you can just keep in your head. Really, the biggest thing is since we have such available and easy testing, just do a blood glucose if you think someone has symptoms, right? Especially if they have diabetes. So physiologically, why do we see this? Okay, and what are the symptoms? So really counter-regulatory hormones start when your blood glucose is between 3.6 and 3.9. So that includes glucagon, cortisol, growth hormone. These are all things that have the opposite effects of insulin and inhibit insulin and cause increase in your blood glucose to get you away from this badness at the bottom here. Now, the reason that you get neurogenic symptoms, which usually happens when your blood glucose is below 3.1, is because one of the counter-regulatory hormones has other effects that you feel as well, and that's epinephrine or the catecholamines that are released from the sympathetic nervous system. And so these cause, you know, when you think about it, epinephrine being released, you can think of that as kind of like a physiological effects of a panic attack. So I'm sure some of you have unfortunately experienced that, or you know someone who's experienced it. So you know, you feel like you're dying, you're diaphoretic, you're tachycardic and palpitations, you're breathing quickly, short of breath, you're tremulous, you're super anxious, maybe you're nauseous, feeling like you're gonna puke, right? Those are those classic features, and those are those epinephrine neurogenic symptoms. Now, the issue is that you can become unaware. So this is that warning sign before the real symptoms start. So this is a side effect of your body doing an appropriate response to low blood glucose. But if you go much further than that, you actually get down to neuroglycopenic symptoms, which are the real big deal. So what happens and why are people hypoglycemia unaware? So again, what you're losing is you're losing this warning sign, which is dangerous, obviously. And this happens as you get older. You just get basically a blunted response from your nervous system. You know, it happens from autonomic neuropathy, one of the neuropathies that can be a complication of diabetes. So it's kind of a double-edged sword that diabetes makes you at risk for hypoglycemia and also can give you a complication that makes you not feel it coming on, okay? And the more frequent you're having hypoglycemia episodes, so in general, like basically poor glycemic control, will predispose someone to being hypoglycemic unaware and more likely to have morbidity due to hypoglycemia. Now, the things that we really want to avoid, remember that first slide, that thing that drives us, that satiation, that hunger is brain energy. So neuroglycopenic symptoms is just brain starvation. So at first it starts off with confusion, maybe some altered level of consciousness that you can see in exam, can progress to other neurological symptoms like weakness, difficulty speaking. But pretty quickly, especially once you get below 1.5, you have seizure, coma, death, okay? So you need to avoid these things. The main risk factors for this that can drive you down again, is having lack of these counter-regulatory hormones or lack of those pathways with gluconeogenesis. So if you have liver disease and can't do gluconeogenesis, or if you have kidney disease and you're losing glucose in your pee, those can predispose you to hypoglycemia. And then really the biggest risk factors is diabetes itself and the medications we use in diabetes to keep your blood sugar low. Insulin and sulfonylureas, which help you secrete insulin, okay? And we'll go through that in a bit here. So treatment's super simple. Basically, if you think someone's having it, so someone has any of Whipple's triads, their blood glucose is low, they have any symptoms that could be neurogenic or neuroglycopenic, or you want to see if it just resolves with giving glucose, give the glucose, okay? People should have juice around, should be available to them, right? Especially in key locations like where they're driving, like in their car, type 1 diabetic, someone who is at high risk of being hypoglycemia, especially if they have hypoglycemia awareness, should have sugary, quickly administered options around everywhere, okay? Or we can give them D5W if they're in the hospital. And then the other thing is glucagon. So a glucagon kit is basically the EpiPen of a diabetic, and it should be around them at all times. If someone's seizing, someone goes into a coma, has severe neuroglycopenic symptoms, or you think they do, themselves and others around them and healthcare professionals need to be trained to give glucagon, okay? There is other causes of hypoglycemia, like an insulinoma, but they're extremely rare, okay? Really what you're gonna see is you're gonna see someone who has either undiagnosed longstanding diabetes or known diabetes comes in on these medications that can make them hypoglycemic. They've been there before and they may or may not be unaware, so they don't have much warning signs, okay? We've got a couple questions on the slide, so we'll go through that to highlight some key points. Okay, we have one from the last slide. Okay, sorry. So in our small group, our preceptor mentioned that the arterial blood gases have been changed to doing venous blood gases. Is this your experience specifically for testing diabetic emergency? Yes, VBGs are often used instead of ABGs just for convenience sake, and they still are quite reliable except for those couple parameters I mentioned. Okay, with someone with type 1, they have repeated hypos. At one point, is their glucagon stores depleted? Say if they have a low one day, would they be able to rely on glucagon the next day, or when again? That is a great question, which I have no idea what the answer is to. I believe that I don't think that plays a big role, but that would be a great question for an expert like an endocrinologist. I don't believe that glucagon is readily used up, and you'll run out of it, and that can be a major factor, but I'm not sure. Okay. Could the EpiPen also be the EpiPen of diabetes if epinephrine is a counter-regulatory hormone too? That's a great point. Good thought. Maybe it should be studied. Okay. So we'll take a 5-minute break here and feel free to post some questions. I'm just going to grab some water myself, and then we're going to go into management of diabetes. We're going to go through the mechanism of actions of pharmacotherapy as well as insulin, and then we'll finish things off. It'll probably just take a quick, 15, 20 minutes to go through. So I'll give you guys a few minutes. Take a break, post any questions that you guys have, and then we'll finish off these slides and we'll be done by 2 hours. Okay. Okay, I hope I gave enough time for some of you to run off the washroom if you had to, or grab a drink, etc. But we'll kind of just keep chugging along here. So yeah, let's move on to management. So obviously the conservative, I kind of break this down into conservative pharmacotherapy and more invasive management options. And so we'll start with conservative. So dietitian referral really should happen every time. You should offer this to every single diabetic patient. I know we're getting taught more on, obesity and the different, treatments and being able to counsel patients better in this area. But I think you're doing a disservice if you're not, getting them to the experts, especially when you look at the effect it can have. A1C down 1 to 2. You'd be hard pressed to find many medications that can even have that such a profound effect. So these really intensive lifestyle modifications are actually one of the few things that have been proven to decrease mortality. So remember we talked about glycemic control really only helps those microvascular things. Well, lifestyle interventions and profound changes in lifestyle interventions can definitely, supporting them well, can definitely have a huge impact. So, in terms of diet causing a decrease in A1C, definitely it can help with that glycemic control, but it also has other broader effects on sort of that complex hormonal dysfunction we talked about earlier. Don't forget, we're treating comorbidities as well. So obesity is a very common comorbidity within diabetes. So weight loss is an important thing to talk about at some point. This is just such a huge topic. It opens up so many things that you can talk about with a patient. And then alcohol cessation, right? Mainly for that cancer risk, right? That's probably the biggest thing. And then smoking cessation again for that cardiovascular risk factors. So do not forget about these conservative things, and do not forget that you have to continually readdress and continually support these things with a patient. Okay, super important. One of the few things we have at our disposal, which actually can reduce mortality. So next is pharmacotherapy, and we'll go through this in more detail on the next slide. But really, again, you have to have a lot of knowledge in this area in order to make good decisions. So I'm going to try on the next slide to give you some of those really big key difference, game-changing characteristics of different pharmacotherapy options that would make you choose it in certain circumstances over another, okay? But you have to consider cost, so big now, especially. So you have to say, do you have drug coverage? Some specific newer medications tend to be more expensive and quite prohibitive from a cost perspective. What's the route, right? Especially with diabetes, a lot of the most effective medications in terms of glycemic control and cardiovascular risk reduction are actually subcutaneous and injected, which is a whole new thing that a person has to learn, which causes its own complications. You have to think about other indications. Okay, you have to think about risk reduction. Not only how much does this lower their blood glucose, but is there alternative effects that are beneficial, like lowering the cardiovascular risk independently? What are the side effects? Hypoglycemia probably being the first one that should jump to your mind as being, really something you have to think about in terms of medications. Like, what is this person's risk of hypoglycemia? How am I changing that with this medication? And then you also have to think about renal and liver dosing. Obviously, there's often comorbidities with liver disease or with renal disease in patients with diabetes. So you have to really think about, contraindications for different levels of function from a renal and liver standpoint. In the end, you'll get used to these, and these will be kind of second nature as you go along. But really what you should be thinking about is some big concepts. So really, there's two main types of medications in terms of broad categories. There's oral. So you should always start with metformin, and we'll go through metformin on the next slide and why that is. But often you do need combination therapy. And again, over time, insulin resistance goes up, beta cell function goes down. So you're going to be needing to add on therapy to maintain your A1C goal of 7 to 8.5 here, okay? Now, injectables, which is mainly insulin as well as others, but you have to really consider starting insulin if someone is symptomatic. So again, on that spectrum of a type 1, asymptomatic, no complications yet, all the way up until someone being either a really severe type 2 or a type 1 where they have really a complete insulin deficiency. those people that go towards that more complete insulin deficiency are the ones who have symptoms: polyuria, polydipsia, constitutional fatigue. Okay, so those are the ones that you have to think about starting insulin, because they might be type 1s. Okay, so anytime someone has symptoms, think about starting insulin right there and then. Okay, which obviously is a big thing to do in the moment. And then A1C above 9, even if it is a type 2, so let's say they don't have symptoms, but their A1C is above 9, it's hard to get that down as quickly as you wanted to get it down, right? You probably want to get that down over the course of weeks to months. So you're going to be adding lots of medications, adding, really drastic conservative lifestyle changes in order to get that 9 down to something like 7 in a few weeks to months. So at that point, you really should just consider starting insulin. And that's some guidelines recommendation on that too. And then you have to think about, what other things am I going to treat, right? So what other risks or what other manifestations do they have of this disease? So, if they have ischemic heart disease, boom, you immediately have to start them on ASA, statin, A/ARB, beta blocker, right? So there's lots of things to consider about comorbidities, but the big ones you should be always thinking is like, do I have an excuse? Really, that's what I think about it as, is do I have a good excuse and indication? And I'm going to look really hard for it to start an ACE or an ARB. Do I have a good indication that's evidence-based to start a statin? Do I have a good indication to start ASA 81? Unfortunately, all of these medications have fallen a little bit short in terms of just blanket statement, diabetes, yes, start them. But there is more and more movement to having a really low threshold for starting these. For example, ACE inhibitors, if anyone's hypertensive and you have to put them on an antihypertensive, if they have diabetes, you should use an ACE inhibitor. Now there's some guidelines that are suggesting in type 2s, if they've been a type 2 for like 3 to 5 years, you should start a statin. So these thresholds are getting lower and lower. So these medications are other things that you have to think about as well. Lastly, I'll just kind of touch on invasive methods. So remember that it is quite invasive to have to do multiple daily subcutaneous injections. Okay, so that's a huge ordeal in and of itself that people have to overcome. Also, insulin pump, implanted blood glucose model like the Freestyle Libre, where you can just scan it. Those things are invasive, but they actually can maybe be desired and convenient for a patient. And then the holy grail is sort of the artificial pancreas. And I know that there's pancreatic transplants, but there's lots of problems with transplant in terms of an immune response and graft versus host. So artificial pancreas is really that holy grail, and who knows, maybe one day we'll have it. So I wanted to go through the physiology of these medications, and what I've done is I've broken them down into all of their major classes. So that means that you cannot use multiple medications from the same class. You have to pick one. Okay, so that first one that you're always starting with, the oral anti-hyperglycemic, is metformin. Okay, so of course, I actually think there's a little bit of evidence for metformin in type 1, but this more broadly applies to type 2. Type 1 is going to be insulin, right? They have an absolute insulin deficiency. In order to correct things, you need to give insulin. But I think there is a bit of evidence of even in type 1 using metformin for some benefit, but it's not routinely done, that's for sure. In type 2, though, we have great evidence that metformin lowers your cardiovascular risk, including macrovascular and mortality. So this is a medication that every single diabetic should be put on, and put on right away. It's fairly well tolerated, mainly has GI side effects like diarrhea, upset stomach, things like that. It's very cheap, and its mechanism of action is this actually works through sort of these other regulatory pathways to decrease your insulin resistance and increase your efficiency of mobilizing glucose. So what that means is it has effects on these transporters going into the muscle. It has effects on the liver and how the liver does gluconeogenesis. And then it also has effects on how the adipose tissue hormones are released. And so it's pretty complex. And honestly, we don't understand the mechanism that well. But basically, it's a peripheral effect. It doesn't directly act on insulin or the pancreas or blood sugars. It basically causes these changes in these metabolic dysfunction to increase the efficiency of glucose getting into where it needs to be. Okay, and it has a pretty good effect on A1C. Remember, not quite as good as those dietary changes, but pretty good. The next class of medications is the incretins, and really these are the hormones that kind of talk with your brain and your gut. Okay, they can also talk with your pancreas and modulate how much insulin you're releasing a little bit, but mainly what they do is they tell you when you're full and they tell you what you should be craving and what you should be eating. That's their main mechanism of action. Now, the interesting thing is they come in two forms, an injectable subcutaneous and an oral form. So obviously, of course, just naturally, the injectable form is super expensive, works much better, and has that highly coveted cardiovascular risk reduction, okay? So this is the one that you really want to start people on. Again, it affects satiety and how much you want to eat. So it does have weight loss. This has been proven in clinical trials. And then the main side effects are GI related. So nausea, vomiting, and quite rare, but definitely serious is pancreatitis, okay? So GLP-1, it's very expensive. I'm always telling my obese diabetic patients, you got to get it on a GLP-1 agonist, and they tell me it's too expensive, or yeah, I tried it, but I was too nauseous, etc. And it has pretty good effect on A1C. Now, DPP-4 is the oral version. Basically, it's a weak GLP-1 agonist, and unfortunately, due to that weakness, you lose things like the cardiovascular benefit. You lose things like the increased A1C reduction. So honestly, DPP-4 inhibitors have fallen out of favor recently, and they're not used that often. All right, our next new big kid on the block, or big new kid on the block, is SGLT2 inhibitors. So again, what they do is they actually shut off gluconeogenesis in the kidney and reabsorption, and they block SGLT2, and you get more glucosuria. So naturally, what you can expect from that is basically you get an osmotic diuresis, so an effect on blood pressure, so you get an antihypertensive effect. Because of that, you get the side effects of an antihypertensive, so you can get hypotension, right, and orthostatic hypotension symptoms. You also get the effect of, or the complications of glucosuria, which is a UTI. And again, the really rare, I mean, this is, I'm pretty sure, incredibly rare. Not many people have probably even seen it in Calgary, but you can get the euglycemic DKA with that as well. Now, these are good medications because they decrease your CV risk overall. Again, something that we cannot do through other means. And it's a oral daily tablet. Problem is, it's very expensive, okay? There used to be, and still is to some degree, some concern about increasing amputation risk, but that's been not disproven, but further clinical trials have not demonstrated that same increased risk. So I don't have much issue or concern about that. Next, what we have is the secretagogues, okay? And what these are is your sulfonylureas and then your meglitinides. And there's a couple examples of the common drug names within those two classes. But really what these do is they modulate what your pancreas is sensing. So remember how GLUT2 senses, and then there's like these complex cellular messaging pathways that actually cause your pancreas to synthesize insulin and release it. Well, basically sulfonylureas are just attaching to different enzymes within that pathway and modulating up how much insulin you release. You take it with each meal, and it's an oral tablet. They're quite cheap. Now, anytime you increase the insulin in someone's body system, you have risk of hypoglycemia. So you can either do that directly with insulin or indirectly with the secretagogues. Now, people often say, you know, like the secretagogues, they're risky. You know, you have to take them very often. There's some question about how well they work, but in the end, they're cheap. They work just as well as metformin, decreasing your A1C by 1 to 1.5. So they're often used. Like a cheap option for a double oral anti-hyperglycemics is combining metformin and sulfonylurea. So someone who's at low risk of hypoglycemia, that might be a reasonable option, and it's cheap, so they can afford it. That's often something that you'll see happen. Now, the last sort of category is insulin itself. So the big thing of insulin is it's what's in our bodies, first of all, right? So it has a predictable physiological response, and we can also give you as much of it as you need, okay? So people who have hemoglobin A1Cs of 15, 16, crazy high, you can still use insulin and eventually get their blood glucose under control, okay? So it has an infinite potential effect in terms of bringing blood glucose down, and it's the only medication that we can say that with, so it's really special in that regards. Now, you have short-acting, intermediate-acting, and long-acting. And again, the big risk here is hypoglycemia. The other thing that people really worry about is weight gain, okay? Definitely, you're utilizing more energy. More energy is getting stored as glycogen and as fat. You're not burning as much fat, so you gain weight. It's just a natural consequence of it, okay? The other ones that work through different mechanisms, like the alpha glucosidase inhibitors that work on the gut digestion and absorption, aren't often used, mainly due to side effects, and it has quite a modest effect on A1C. And then the only other one to keep in mind is the thiazolidinedione, however you say that, and it worsens CHF and increases mortality. So of course that's fallen out of favor to be used. Okay, so I hope this is a helpful physiological slide to help you know the drug classes and where they have an effect and influence. Okay. So next, what I want to do is just talk about diabetes a little bit. If I can advance the slide here, here we go. So with diabetes, you know, sorry, insulin, I should say. So with insulin, so again, when do you start insulin? So when it's someone who needs insulin, right? So no matter how many oral anti-hyperglycemic medications you give, you're not going to have enough effect when someone has an absolute insulin deficiency. So type 1 needs insulin. And then also, when you look back at this slide, you know, there's not a ton of options here, right? You can pick from each of these categories. So you can do the conservative things. You can get someone doing a great diet. They've lost some weight. They're not smoking. They're not drinking. But really, if you add all these up, let's say they're on a metformin 1.5, they get lucky, 1, 2.5. SGLT2 only goes down half. So they have 3 points. The secretagogue they use as well. So really, maximal effect is about a reduction in 4 in your A1C. Okay, so you eventually hit a wall with oral anti-hyperglycemics and you have to start insulin. So really what we want to do is we want to recreate the natural physiological levels of insulin throughout the day. So how we do that is basically what your pancreas is doing is when you're fasting, it's sensing a little bit of glucose, right? A normal serum amount, and it's releasing just a basal level of insulin. And that basal level is recreated by long-acting basal insulins, okay? And what this primarily does is it is a balance to your counter-regulatory hormones, and it is that little bit of insulin that you need to inhibit lipolysis in your body, okay? So this basal insulin should always be continued in a diabetic, no matter what their blood sugars are. I mean, you may have to adjust it up and down, but let's say, for example, someone gets sick and they're not eating at all, they still need to continue their basal insulin, because if they stop it, lipolysis will happen because it's no longer being inhibited. There's no insulin present, and DKA happens. Okay, so when a type 1 diabetes or a type 2 gets sick, you got to tell them continue your basal insulin. Okay, you're inhibiting lipolysis and you're just balancing out those counter-regulatory hormones. Okay. Next, what happens is when you get these big challenges with meals, and so that's why you have to add on the short-acting insulin. Okay. Now, this is basically the goal that you should strive for when using insulin. Okay. Oftentimes you just start with basal insulin. So when you're transitioning a type 2 diabetic who all of a sudden, based on meeting their A1C goals, needs insulin, what you would do is you would start with basal insulin, and that might be enough. You might start with just like a nominal number like 10, which is a fairly low number of units to give for basal insulin, and that's what you would start with. And then with a type 2 diabetic, as they progress, you may need to add in these short-acting insulin injections for meals. With a type 1, now people are saying, okay, I get the pattern. I need meals to have short-acting insulin to combat those high rises in blood glucose that's coming in through my meals. And I need a basal continual dose throughout the day. But what are these doses? So there's a couple simple formulas, and I have them written in the notes of the slides that you can look at later. But essentially what you can do is you can take someone's weight and divide it in half. That's their total insulin daily, okay, from all sources, short-acting and long-acting. So a 100-kilo person, 50% would be about 50 units of insulin. And then what you can do is you can divide that up, about half of it in the basal insulin and about half of it in the short-acting. So the numbers won't be too pretty here, but if we cut 50 in half, that's 25 units for basal insulin, and then another 25 units divided by 3 for each meal. So 25 divided by 3, is roughly 9 units. Let's just say 10 units. We're giving them a little bit extra. So you'll give them 25 units basal and 10 units of short acting with each meal. Now, this of course can get much, much more complex with carb counting, individual variation, but that's just a starting point. And then what you need to do is you need to have them monitor. So you need to have them taking a blood glucose before each meal, right? So when you take a blood glucose before breakfast, this basically tells you how well is this basal insulin holding you overnight, okay? And then you have to take a blood glucose measurement right before lunch. And that's what you're basically saying is, did I take the right amount for breakfast? Did my insulin dosing match my insulin needs, okay? And then if it did, you take the second one, right? And then you measure right before supper, right? And that tells you about your lunch dosing and how appropriate it was. And then you take the last one right before bed, and that tells you how appropriate your dinner dosing was. If things are elevated only at one point during the day, then it indicates that dosing that I just mentioned. So if it's in the morning, you're very high, you should think about if that is due to your basal insulin not being high enough. If your midday right before lunch is very high, maybe it's because your morning isn't very high, or maybe it's because your morning insulin isn't high enough. If right before dinner is too high, maybe it's because your insulin at lunch isn't high enough and isn't appropriate. If you're high right before bedtime, that may be due to your dinner time insulin, okay? If you're high everywhere, increase your basal dose, and you can increase also your short-acting insulins, again, to keep that relative ratio about 50-50, okay? You want about 50% long-acting, 50% short-acting, and these are all just guides. People will have variations in this, some people quite drastically, but this is a good starting point and a fairly safe starting point. Okay, once a type 2 diabetes patient starts insulin, do we continue other drugs like metformin or not? Okay, great question. So the general answer to that question is yes, as long as there's some benefit from the medication. So in theory, there may be a potential benefit in decreasing the amount of insulin you need, but really the biggest things in terms of other benefits is that cardiovascular risk. So if I go back to this other slide here, really metformin, yes, for sure, decreases cardiovascular risk. You want to keep that effect, so you keep them on it. If they're on a GLP-1, they've lost weight on it, and we know it decreases their cardiovascular risk, they're tolerating it well, you might keep that too. SGLT2, same goes for that, okay? So some of these medications you may keep, but you don't keep them necessarily for their anti-hyperglycemic effect. This is an ongoing area of research though. So you may hear where when they actually test this theory, where they say, funny enough, SGLT2s, when you're not on insulin, decreases your cardiovascular risk, but when you're on insulin, has no effect. So we'll find out in the near future, but I'd keep them on now just in case we do have that beneficial effect, especially if it's well tolerated, both physically and financially. Okay, last bit of the presentation here. So we'll just wrap up. It's 7:55. So I've managed to bore you guys for 2 hours. I'm so sorry, but I hope you learned something. Anyways, for follow-up, so the biggest thing that you got to do is monitor their blood glucose, right? So that's one of the big things that we do to address that end organ damage, right? So you got to monitor it. So if they're not at risk of hypoglycemia, so they're not on a secretagogue, they're not on insulin, they've never had hypoglycemia before, you can do chronic monitoring. So that would be a hemoglobin A1C every 3 months. And if things get boring, like things haven't changed, spread it out, right? Do it every 6 months, do it every year, right? But keep an eye on this thing. I wouldn't do it any longer than a year apart. Q3 months is a reasonable answer. Okay, and then if they're insulin dependent or if they're hospitalized, there's a couple other goals that you have with their blood glucose monitoring. So you have to do that QID blood glucose, like I said, morning before breakfast, right before lunch, right before dinner, and at bedtime, because that helps you titrate the insulin needs of that person, okay? If they've been on a stable dose for a really, really long time, they're really good at carb counting, obviously the discussion may change, okay? But initially, in general, if you're taking insulin, you need to do regular blood glucose monitoring based on pokes, okay? And then the hospitalized blood glucose goal, 5 to 10, okay? That's proven to decrease mortality and hospitalization, so you have to follow that, super important. Okay, next, we want to monitor for those CV risk and complications, right? That's the whole point of doing all of this, is to avoid these things. So you have to monitor for them so that you can address them when they come, so you can see other ones coming on. The more risks, the more complications you have, the more risk of future complications or worsening of those current complications. So it changes a little bit between on type 1 and type 2 diabetes, and you can see that noted there. But so basically you want to cover all the different complications. So retinopathy, retinal exam every 1 year. If they have any sign of diabetic retinopathy, they're seeing an ophthalmologist, okay? No questions asked. Next, you have to monitor for that chronic kidney disease. The first sign that you'll likely see is some microalbuminuria. So every year you do a creatinine albumin ratio to quantify how much albumin they have in their urine. Lipids, you do it every year, super comorbid with type 2 diabetes. So you do it everywhere. Basically, you're just like chomping at the bit to have an excuse to put this person on a statin. And then you do a foot exam with a monofilament every year. And then especially if someone's at risk for it, you may do it more often, and you may tell someone, hey, I want you looking at your feet. If you're unable to do it physically, get a mirror and check out every single piece of your skin on your feet every night before you go to bed. And if you notice any changes, you come talk to me about it, okay? And then you also monitor for that neuropathy with the monofilament on the foot exam. And then again, blood pressure at every visit. Again, very comorbid, and don't forget, you get so much more bang for your buck treating blood pressure as opposed to treating hyperglycemia from macuvascular complication perspective, okay? So if you want to stop someone from having a heart attack, stroke, losing a limb due to peripheral vascular disease, you treat their blood pressure aggressively, okay? And you monitor it aggressively. And then lastly is safety. So last but not least, right? Glucagon, one we talked about, that saves lives. It's the diabetic EpiPen, I call it. And then also don't forget things about like driving and medical alert, because those things can save lives, and they can be things that patients are unaware of or won't think about, okay? So you have to be comprehensive. Okay. Couple questions here. Okay, looks like those are just not very general questions, so I'll answer them in a second. But if there's any other questions, feel free to come up via voice or via chat typing, and feel free to ask, and we can go through some things again. So the one question I got asked about was the Dawn phenomenon. Is that too detailed diabetes management? I would say yes. Basically, the reason I say that is because, like, even for me, it like rings the bell, but I don't even know what it is off the top of my head. Okay, so I'm glad you found this helpful. I will stop recording now, and I'm going to give this to Dr. Bessuni to upload, and then there's a review tomorrow. Geez, off the top of my head, I want to say 2 p.m., but you have the email, so check it. And it's Dr. Dan Myers. I'm not sure if he's a real doctor. He passed med school, but their graduation was canceled, so he's kind of in limbo. I'll call him a doctor for now. He's going to do a review on hyponatremia, and he can also answer some basic physiology nephro questions, or probably even a little bit more than basic. So that might be helpful. So feel free to join in then. And then I think maybe early next week, we'll start up with some more reviews. Okay. Thanks for joining, everyone, and I hope you have a great evening. And feel free to post any questions. I'll be on here for a few minutes, just kind of getting working.